medical teams, the surgical teams, the nursing teams, they can follow BFAST, and then they can recognize stroke and call for help early. Okay? Whether it's calling us or calling 999 or whatever, and this is within hospital. Okay, because it's not only the public that don't actually know how to recognize a stroke, it's my colleagues. Okay, and it's really, really, really frustrating when we get called late. You know, I get called where the patient has had right-sided weakness for 2 hours. Okay, by then we've lost time. Brain cells are dying. Okay, so that's why it's really important to act fast. Be fast adds in a little bit more. So most strokes happen in the front of the brain. Okay, and hence why you get the face, the arm, the leg affected, the speech. Okay, but symptoms from the back of the brain are not always that. Okay, you can get balance problems. So as I said to you earlier, if you remember that brain picture with all the colors, cerebellum is for your balance. It's your balance center. Okay, so you wouldn't necessarily get weakness in your arms or legs, but you won't be able to walk suddenly. Okay, you can get sometimes severe headaches. You can get dizziness or vertigo. And E stands for eyes. So sudden onset change in your vision. Okay, we're not talking about a gradual, oh, I've got blurred vision for a long time, but I've got a cataracts. I'm talking about a sudden change. So a sudden, for example, a curtain coming down in your right eye, like a black curtain, and then it gets better, or complete loss of vision in that eye. Yeah, that is not usually going to be a cataract or an eye problem. That's going to be a stroke within the eye. Okay. Or double vision, you know, or loss of vision from one side. So you could look through both eyes, but you can't see that right side very well. You're missing that area, or the left side. So this is why BFAST is something that I want to push through a bit more, so that you know that you can recognize strokes at the back of the brain and the front of the brain. Either way, if any of that happens, call 999. Yeah, parts of the problem is lack of stroke education. So it's one thing me coming here and educating you, but that's one step at least, you know, because if I educate you guys as much as I can, then you can tell the next person. Okay, and that's the idea for the general public, because all I want you to do is recognize some symptoms and call 999. Okay, the problem is I've seen, and it's happened with one of my best friends recently, okay, is you go to a hospital, a stroke center, a regional stroke centre, like Charing Cross or another one in London, and you come in with stroke symptoms, but they don't fit fully to BFAST. Okay? Yeah. For example, numbness. Numbness is not on there. Okay? So then people don't triage you as an acute stroke. Okay? So they don't allow you to go through 999. You come to A&E, and then a triage nurse thinks, okay, it's not fast. You can wait in the waiting room. Okay, but the idea is making sure that clinicians in the hospital at the front door also know this. It's a know about that there are other stroke symptoms if it's anything that's of sudden onset, focal neurological deficits. So that's the thing I need to push through to them. And I've been doing that at Chelsea and Westminster, and we're trying our best. Unfortunately, people who don't see strokes all the time don't know what to do. I see it with junior doctors, I see it with my colleagues like A&E consultants. They're scared of stroke. So we try and educate, but unfortunately some people get missed. But it's not okay. I don't know what the answer is, apart from education, as much as we can do. Let's move on. So, I'm going to talk to you about hyperacute management of stroke. So hyperacute management is essentially management of a stroke within the first 24, 48 hours, okay? So as a stroke comes through the front door, so this is the stuff that I do at Charing Cross Hospital, okay, which is our regional stroke centre. So a patient comes in with stroke symptoms, as we've discussed already. We need to decide what to do, okay? As we've discussed previously, I've just put 2 slides there, just 2 pictures, and they're both CT scans. Just so that you know what I'm talking about when I talk about an ischemic stroke. So a clot that's blocked a vessel, and a hemorrhagic stroke where a bleed has happened, and what I see in the scan. Okay? So quickly we'll go through ischemic stroke. So if you see on the scan on the left side, and now on the right side of that scan you can see a dark area. Yeah? You appreciate that. So that is the area of infarcted tissue. So this is the area of dead tissue, okay? Because a clot has blocked the vessel for long enough, and that area of the brain dies, okay? That area of the brain on that scan is actually the left side of the brain, okay? So that person could have lost their speech and might have right-sided loss, okay? Those patients, if they present early, okay, then we can do thrombolysis and give them clot-busting medications. We can also deliver something called a thrombectomy, where we go in, not me personally, I don't know how to do it, but my colleagues, our radiologists, can go into the vessel, through the groin, find the vessel, pull the clot out. Okay, so there is things that can be done. So we're much further than where we were before, which was just rehab, essentially. So that's why presenting early is really important. And this is why education, again, is really important. And then we go on to blood thinners and vascular risk management, which we'll talk about later. I just want to bring a case for you that I actually saw on Wednesday. It is, it will stay with me for a very long time. It was an 18-year-old young man. Okay, 1/8. He was a strong rower. He was due to start rowing for Great Britain in the Olympics. He was due to do his A-levels in two weeks, and he had a place at Cambridge. Okay, so I was on call at Charing Cross that day on Wednesday, and I got a call from my registrar to say we've got a patient who's presented within 1.5 hours. So I come downstairs into the CT area, and he can't move his right leg at all, okay, and he can barely kind of move his hand. He can't lift up his arm, okay. So I'm there trying to explain to this young man and his parents, who are in pieces, as you can imagine, that this is most likely is going to be a stroke, or we have to do something. So they're asking me what are the risks of treatment, and I had to clearly say to them, I cannot wait. Please just give me the consent to give this young man the blood thinners, the clot-busting medications, because he's within the time window. He's within our 4.5-hour window to give him treatment. Okay? I mean, took a bit of persuasion, but I said, I can't leave him like this. Okay? Because he's going to be left with significant disability if we don't do something. They said fine, eventually. And then he was like, yeah, okay, do whatever you need to do. Okay? He could talk, so it was fine. Anyway, gave him the clot-busting medication. He didn't have any risk factors for stroke that we knew of. He was fit and well. Okay? Gave him the clot-busting medications. Within 40 minutes, it's a bolus. It's literally you give it over 1 minute, and then you give the rest of the infusion over an hour. Within 40 minutes, this man's leg started to move. So he lifted up his leg. I kept going to see him that evening, and after 24 hours, I checked, and actually, he was walking. The only thing is his arm was a bit weak, like this, but he was walking, he had the full strength, okay, and he was discharged 2 days later. So this is why this is why I say it's so important to act fast, or be fast. And as much as, yes, there's people that don't do it, they don't understand, they miss things, they sit people in A&E, in waiting rooms, and I think a lot of the time it's not because they want to, it's because of the burden that we have in the NHS. Unfortunately, we are working very hard in a system that is very difficult, but we will continue to do our best. But these are the cases that really make me happy to know that we do the right thing, to make this man's life has now, he's still got a life. He could potentially run for GB. Hopefully we'll be able, probably not to take his A-levels in 2 weeks, because he can't, because I've said that. But, hopefully he'll go on and go to Cambridge and continue with his life. Obviously, in the background, we're looking at wireless agent, okay? But he's currently on blood thinners to reduce the chances of another stroke. Yes, so young people do better in general, okay? Because they have more strength in them, okay? Yeah. But also, I think what's helped him is the thrombolysis, the clot busting. There was a clot blocking a vessel, we gave it in time, and his symptoms improved, okay? But, I genuinely don't think without that drug, he would have been where he was. The reason being, when we did an MRI scan the next day, he had strokes all over his brain on the left side. So his tissue had already damaged. damaged, and if you do the scan on the review, it'll still show the damaged tissue, but his function is better, and that's the key. So.